very good and modern. So introduction wise, we all know it's a uterus, Greek hysteria womb. We can say it's a child-bearing organ. It provides a suitable site and environment for the implantation of the fertilized ovum and development of the embryo. Then is situated in the pelvis between the urinary bladder and the rectum. It's a thick-walled muscular organ with narrow lumen. And it's between the urinary bladder and the rectum, and superiorly of each side it communicates with the uterine tube and inferiorly with the vagina. It's nothing new I'm going to talk about, but it's just a revision. This is the uterus, which we all know. It's a big full photograph of this. So what are the parts of the uterus? It is divided into two main parts: large upper body, this one, and the body, and the small lower cylindrical part is the cervix. The body forms the upper 2/3 of the uterus, and cervix from the lower 1/3 of the portion. It's a junction between the body and cervix, is a circular constriction. It is called the isthmus. So the point of fusion between the uterine tube and the body is called the cornu of the uterus. So you all know everything, but still we are just doing revision of many more things. So what is the size? Why we are discussing about the anatomy of the uterus? Until and unless we are not correctly knowing the anatomy of the uterus, the positioning of the uterus, the size of the uterus, the shape of the uterus, as we know, it changes with the adenomyosis, when the fibroid is there. All these things changes with all the FIGO classification of AUB, and we know so many things about it. So we should know the size and shape, how it has been anteverted, retroverted, it's a deviated, how adnexal masses are there, it's a transverse diameter more or the anteroposterior diameter more, are all important things. So measurements, length is basically 7.5 centimeter. Breadth is at the fundus 2 inches, that is 5 centimeter. Thickness is a 1 inch, that's a 2.5 centimeter. And the weight of the normal uterus is 30 to 40 grams. Whenever we talk about the vaginal surgery courses, the weight of the uterus is a prime thing. What the weight of the uterus, what is the volume of the uterus, are we able to deliver it from down or not? The weight is so important. So all the measurements are also important when we do the vaginal hysterectomy. That's another important point. Now, what is body of the uterus? It's above the imaginary line, horizontal plane, passing through the opening of the uterine tube. So you can understand when the uterine tubes, I'm just drawing this thing over there. And you can see, just a note like this, I can show you. Yeah. So you can see this mouse is going from this, and we can see this is the expanded dome-like end of the body, fundus. The fundus is a convex all sides and covered by the peritoneum. So it's all covered by the peritoneum and extends from the fundus to isthmus. It's fundus to isthmus. This is up to this level, and extends from the isthmus and contains into the uterine cavity. It is flattened anteroposteriorly and presents anterior and posterior surface and right and lateral surface and borders. So very, very important. Anteroposteriorly it is flattened, because when we deliver the uterus and when we take a photograph, we should know that's the anterior side, posterior side of the uterus for all those things. So how it works? You see the anterior surface, it's flat, directed downwards and forward. It is covered with the peritoneum up to the isthmus. So you can see this green level, it's covered up to the level of isthmus. And when it is reflected to the upper surface of the urinary fluid, it's a uterovaginal pouch. Okay. Am I audible, I think?
Yes, ma'am.
Yeah. So uterovesical pouch. And then the posterior surface, it's a convex, directed upwards and backwards. So this is like this. And it is covered by the peritoneum, which extends up to the posterior fornix of the vagina, and where it is reflected on the anterior aspect of the rectum. So you can see, and this is a rectovesical pouch. Whenever we talk about the uterus, we should know this, both the pouches. Uterovesical pouch is also very, very important, and the rectouterine pouch is very, very important. So this is the reflection of the peritoneum going above and upper surface and reflected on the anterior aspect of the rectum. It's more important. So again, this is another important point, is that this is the anterior abdominal wall, the back of the pubis. You can see the diagram. Everybody can learn from the YouTube or anywhere the diagram, but this course, at least you are able to make it things, because you're sincerely joining it. So you should take it the basics as very simple. So this is the uterus. You have this is uterovesical pouch. Fifth number, this is a recto pouch because this is a rectum. Bladder ahead, this is a pubic symphysis over there, and the pubovesical ligament, which is connecting between the symphysis pubis and the anterior side of the bladder. Then the urogenital diaphragm. We will talk about the pelvic diaphragm soon, and the perineal body also, and a vagina and a rectum. So another important point. So then we have talked about the anterior surface, we have talked about the posterior surface. So we are talking about the right and lateral borders of the uterus. Each lateral border is related to the uterine cavity. See, this is the lateral feature of this is the fundus of the uterus, and this is important. It's a non-peritoneal, for it provides the attachment to the broad ligament of the uterus. And the uterine tube enters to uterus at the upper end of the border, and that's more important. And round ligament is attached to the anterior-inferior to the tube, and ligament of the ovaries attached to the posterior-inferior of the tube. So make it a point, tubes are very, very important. While doing the dissection, we should know these two things, where the round ligament will be and where the ligament of the ovary will be. The round ligament of the ovary will be anterior-inferior of the tube, and the ligament of this ovary will be attached to the posterior-inferior of the tube. So another important point is cervix. So it's a lower cylindrical part, and the lower part projects into the upper part of the vagina through the anterior wall, and cervix again is divided into two parts. Number one, upper supravaginal part. Number two, lower vaginal part. Then you can see in this picture also, that's a fundus, body, cervix and vagina. So this is the internal os, and this is the cervical canal, and we can see the portion of the cervix over there. So the normal position and the axis of the uterus is again very, very important. While doing the examination, it may be the undergraduate thing, but just by putting the two fingers over the cervix and press it posteriorly, and we can feel the uterus upwards. So we can feel the anteverted uterus, and by pressing it, and the uterus doesn't move and it goes beyond, so it's a retroflexion. So the angle of anteversion is 90 degree, that's a position of anteversion. An angle of 170 degree anteflexion, that's a position of anteflexion. So normally uterus lies in the position of anteversion, so that the long axis of the cervix is normally bent forward on the long axis of vagina, forming an angle of 90 degree. Now the anteflexion, see first the angle between the anteversion and anteflexion, the long axis of the body of the uterus is bent forward at the level of isthmus. So you can differentiate the both. The anteversion is basically the angle between the long axis of cervix with the axis of vagina, and this is the long axis of the body, and at the level of isthmus is again the anteflexion is there. So it's forming 170 degree and 90 degrees. So basic, very basic things, but we'll talk about. Now, what are the relations of the uterus? And what are the relations in the anteriorly, what are the posteriorly, and what are the laterally? Because while doing the surgery, if our anatomical knowledge is perfect, we know what is anteriorly, what is posteriorly, how we are going through, and how we are going to cut the thing, and how we are going to deliver. It's very, very important. So anteriorly, body is related to the uterovesical pouch and a superior surface of the urinary bladder. The supravaginal portion of the cervix is related to the posterior surface of the urinary bladder, and vaginal portion of the cervix is related to the anterior fornix of the vagina. See, we are much more worried when we separate the uterovaginal pouch on the reflection of it. So it is very important that the body is related to the UV pouch of the superior in the bladder, so that we are worried at that level. At supravaginal portion of the cervix, it's a posterior surface of the urinary bladder, and the vaginal portion is related to the anterior fornix of the vagina. So we are safe when we are at the vaginal portion of the cervix. We are very much safe. But when we doing the surgery, we go anteriorly and the things are there. What is the posteriorly? The body of the uterus is related to the rectouterine pouch, which coils of ileum, sigmoid colon in it. The supravaginal portion of the cervix is related to the rectovaginal pouch, and the coils of ileum and sigmoid are there. So while opening the pouch of Douglas, we are worried about all those things. The coils of ileum can come, the sigmoid colon is there. So we should be worried. So the body of the uterus is only this thing. And the vaginal portion of the cervix is related to the posterior fornix. Again, laterally, the body of the uterus is related to the broad ligament and the uterine and the artery. And again, laterally, supravaginal portion of the cervix is related to the ureter and uterine artery. and the vaginal portion of the cervix is lateral to the lateral fornices. So, vaginal portion of the cervix, we are worried about the anterior fornix, posterior fornix, and the lateral fornices. Supravaginal portion of the cervix, we are worried about the posterior surface of the bladder, and the supravaginal portion cervix is related to the rectouterine pouch with the ileum and the sigmoid colon, and the supravaginal portion of the cervix is related to ureter and uterine artery. So, you can justify it's the same diagram which we already have shown, uterus, so rectovaginal pouch. This is the uterovaginal pouch, how this portion is related to the bladder, and this is the colon, this is the rectum over there. So how we are connected to all of these things. And again, all point are there. So what is the cavity of the uterus? Cavity is a small compression in the size due to the thick muscular wall, and it's divided into two parts, cavity of the body and the cavity of the cervix. You can justify this is the cavity of the body, and this is the cavity of the cervix. Just put a diagram drawing so that I can draw over there. Just make it a point. It's okay. So the cavity of the body of this is a triangular at the coronal section, and apex of the cavity continues below with the cervical canal through internal os. And the implantation commonly occurs at the upper part of the posterior wall, and it is slit of the sagittal section because the uterus is compressed anteroposteriorly, and anterior and posterior wall are almost in a contact. Because of thick muscular wall, the cavity is almost this like this. So at the level of external cos is a circular in the posterior lip. This is the cervix at the external cos. So the cavity of the cervix is a spindle canal, being the border of the middle and narrow at ends, communicates anterosuperiorly with the cavity of the body of the uterus and through internal os, and inferiorly with the cavity of vagina through external os. A nulliparous woman, as an external os, is small and circular, but when the multiparous women, we should be given the birth of 2 or more babies, the X are large, transverse, and presents to post the anterior and posterior. Why I am talking about this thing is very, very important. Reason being, when we do the surgeries into the nulliparous uterus, and when we do the surgeries into the multiparous or the gravida 2, gravida of the para 2, para 3, the external os, anterior lip are very, very important to know. Now the important points. The whole time we talk about the ligaments, who are the supports, how the uterus is being supported. Why we should know about the ligaments and the support? Because we are worried about in future about how we are dealing with the prolapse, how we are dealing with the vault prolapse, why vault prolapse happens, and all this. The ligaments of the uterus are classified into 2 types, false and true. The false ligaments are basically the peritoneum folds, and whereas the true ligaments is a fibromuscular bands. The false ligaments do not provide support to the uterus, while true ligaments provide support to the uterus. So basically, the false ligaments are the broad ligaments, and the rectouterine folds, they are paired because on both the sides. Uterovesical fold, anterior ligament, or the rectovaginal fold, that's a posterior ligament, they are unpaired because they need a 1-1 over there. Then the true ligaments are round ligament, transverse cervical ligament, and uterosacral ligaments and pubosacral. These all are supporting for everything over there. So the true ligaments, round ligaments, again they are paired one. The transverse cervical ligaments, the broad one, the muscular, they are also paired one. Uterosacral ligaments, which are going back, they are also paired one, and a pubocervical ligaments are the paired ones. So now after the ligaments, we are talking about the arterial supply, how the uterus has been supplied. We should know because in the right side of the uterus, it's directly from the aorta, and the chances of bleeding are more on the right side when we do surgeries rather than on the left side because the bleeding is directly from the aorta. So we should know the arterial supply. The uterus is supplied mainly by 2 uterine arteries, partly by 2 ovarian arteries. So make it a point. This is the ovarian artery and this is the uterine artery. So uterine artery is a branch of anterior division of anterior internal iliac artery. It crosses the ureter above the lateral to the cervix, above the lateral to the fornix of vagina. So it's very, very important. It comes like this. It crosses the ureter. It goes up to this thing and then enters into the uterus. It ascends along with the side of the uterus and it goes inside. That the supralateral angle of the uterus is turned laterally, runs along the uterine tube, and terminates by anastomosing with ovarian artery. So the blood supply of the uterus, again, just see there are arcuate branches, there are radial branches. The surface is outer 1/3 of the myometrium, arcuate, and radial branches is inner 2/3 of the myometrium. They do. And basal arteries is the basal part of the endometrium. They supply, they are more. And the spiral arteries are superficial part of the endometrium being supplied, and the cervical arteries on this part. Now, what is the venous drainage? The veins of the uterus correspond to the arteries. They form a venous plexus along with the lateral borders of the uterus, which drains into the internal iliac, and through uterine vaginal veins they go. They form a venous plexus. This is called as pampiniform plexus, along with the ovarian veins, drains into the internal iliac and with the uterine veins. The nerve supply, which is very, very important. So it's not that much important for the when we're doing the surgery, but we should know what is the nerve supply of the uterus. It's a sympathetic fibers, T10 to L1. Somatic pain distribution, area of T10 to 8. Sympathetic fibers cause uterine contraction and vasoconstriction. So in a labor, this thing, we should know about this pain part is there because of this. While the uterine contraction, sympathetic fibers are responsible, and parasympathetic fibers, spinal segments, and in this is the ganglion of Franklin-Hauser. It's another important point we should know. The parasympathetic fibers inhibit the uterine muscles and cause vasodilatation. Again, the lymphatic drainage, because see, we should know the lymphatic drainage also. If we come about the postmenopausal bleeding and said there may be chances of a cancer, endometrial cancer and anything, we should know the lymphatic drainage also. And that's clinically important because cancer spreads through lymphatics from fundus and upper part of the body. The most of the lymphatic drain and intrapreoperative aortic lymph nodes along with the ovarian vessels. However, the few lymphatic vessels from the lateral angle of the uterus drain into superficial inguinal lymph nodes and along with the round ligaments of the uterus. So this very important, and the lower part of the body, external iliac nodes from cervix, it goes drain directly in 3 directions. Laterally, lymph vessels and drains into the external iliac obturator nodes passing through the parametric tissue, and posteriorly the lymph vessels drain into the internal iliac nodes, and posteriorly again drain sacral nodes by passing the uterosacral. So this is the drainage system. When we talk about the cervix, where it goes into 3 directions. Either it will go to this external this iliac lymph nodes. It can go to the inguinal lymph nodes, the upper one, and the third we can go to obturator lymph nodes, and that can go to this internal iliac lymph. So we should know about the lymph. Now the important point: what are the supports of the uterus? The uterus is kept in the position to prevent from sagging down by a number of structures providing to support it. See, the uterus is there, it can be mobile or anything, but it needs support. So it is subdivided in 2 types. Chief is a primary support, and that is a secondary support. Now, what is the primary support? Number 1 is the muscular, that's a pelvic diaphragm. Number 2 is a perineal body and a urogenital diaphragm. The visceral, there are the urinary bladder in front and vagina and uterine axis. Because of that uterine axis, again, that is a support. And then the fibromuscular. Fibromuscular, there can be McEnrods, transverse cervical ligaments, pubocervical ligaments, uterosacral ligaments, round ligaments of the uterus are there. So you can, I'm just justifying over here that this is the rectum, this is the cervix, this is the urinary bladder. We can see this is the transverse one, the ligament, and the uterosacrals covering and going towards the rectum, and urinary bladder is the pubocervical. These all are paired, and that's the important support. Now the secondary support, uterovesical folds of peritoneum and the rectovaginal fold of peritoneums are there, and the broad ligaments. Broad ligaments cover a very large area. In that you can see the tube, the ovary, all the vessels are coming through, and all this is all important point are there. So broad ligament is basically double layered peritoneum, side of the uterus and the lateral wall of the pelvis. Posterior forms a mesoovarium, which is close to this, and then pierce the lateral fold of the fallopian tube, and anterior layer is free. So it's a flimsy going back, and anterior layer is free. It contains fallopian tubes, it contains ovarian vessels, it contains uterine vessels, round ligament, ovarian ligament, and oophophorane, paraphoran, and ovary attached to the posterior layer. Now, why we are talking all this about? Because we need all this clinical correlation. That's a prolapse of the uterus, the importance of the tone of levator and iamosal and supporting uterus, as already we have to emphasize, and importance of the transverse cervical and pubocervical, sacrocervical ligaments are there. Damage to these structures during childbirth or general poor body are there and called the uterine prolapse. So again, this is a repetition maybe, but I'm just telling you why it's important cervical part lower, and these are the cervical made up of outer stroma, connective tissue. I'm just little pathology, you can say, about it, and smooth muscles and alkaline thick scanty rich mucoprotein like that. So I think this is the repetition. We will talk about the perineal body, but just in this thing, I'm again putting it. I'll show you the video, but it's a pyramid shape. When we talk about the perineal body, it's a pyramid shape fibrovascular mass, about 4 into 4 centimeter. It separates the vulva, vagina. It's a pubococcygeus. It is made up of superficial deep transverse perineum. I'll just show you video and you will come to know about it. So this is another important, but this is a DeLancey's 3 level of pelvic support. Everyone should know about these 3 supports into the pelvic cell. The first level shows that the uterosacral ligament and the cardinal ligament. This is like this, and this going through the rectum and this. Second is the second level shows the pubocervical and the rectovaginal fascia. So you can justify, don't go on the language over written over there, but I'm just telling the DeLancey's 3 levels of pelvic support are important. First level, uterosacral. Second level, pubocervical, rectovaginal fascia. And third level support the superficial transverse perineal vessels and ureter. That's an important thing. And we'll have a different video for this. And this is the histology of the uterus, a single layer columnar epithelium and all those parts. Again, we should know a bit about the squamocolumnar junction at the cervix. That's important. And ovary, structure of the ovary is another important, because we have to know when we talk about the ovary, that at what level the ovary is when we do this, and what the grading of the ovary, where is the ovarian fossa, how is big it is, 4 centimeter, 3 centimeter, 2. The ovaries are surrounded by capsule, have an outer cortex and inner medulla. So again, very, very important. The boundaries of ovarian fossa is important thing, because it has got the external iliac vessel above, behind the ureter and the internal iliac vessels. Floor is by the obturator nerve and vessels, and above inferred, this is obliterated umbilical artery. So while removing the ovaries through vagina, we should know what is the boundaries of ovarian fossa, and why we are most worried about the ureter and internal iliac vessels, and we are also worried about the external iliac vessels above. So again, these are the parts which we should know. There are 2 ends directed upwards, uterine body and suspensory ligament, ovaries, uterine, and then it is attacked by the posterior layer of the broad ligament. This is a mesoovarian border, posterior free border, 2 surfaces, medial surface and the lateral surfaces. Ovary is attached to the lateral pelvic wall by the infundibulopelvic ligaments and carries blood. And again, the volume of the ovary is very, very important. In reproductive age, it's up to 20 cc, 7 to 8 cc. You can see. Hi, we should all know about the uterus. The knowledge of the anatomy of the uterus, it's important in context to the vaginal surgeries. Because in vaginal surgery, we should know what is the size of uterus, how the position, and that's why the anatomy we are going to talk about. In this session, we will talk about the parts and the position of the uterus, the blood supply and the innervation of the uterus, and the lymphatic drainage, and the histology of the uterus and functions, and hysterectomy of the and tubal ligation in the other portion. So here only we will talk about 3 portions up to lymphatic drainage. The uterus is also called as the womb, and it's a number 1 reproductive organ of the body. It's 8 centimeter hollow muscular organ which lies in the female pelvis and related dorsocranially to the bladder. So actually the interior is the bladder and the posterior side is the rectum. Uterus is having 3 parts. The upper portion is the body and the lower portion is the cervix. And in between the 2, that's the portion, small portion is called isthmus. Uterus has got three layers, consists of three major layers, and the histological structures depend upon the proliferative phase. It is perimetrium, myometrium, and the endometrium. These are the three major layers of the uterus. Uterus also divided into the lowermost portion, which is divided into cervix, and the in between is isthmus, and the upper portion is the body of the uterus, or it is also called as body. The cervix is the lowermost portion of the uterus. It measures about 2.5 to 3 centimeter in length. It lies supraperitoneal. Is divided into vaginal portion, that is ectocervix, and a part fixed with the parametrium. It is called the supravaginal portion, that is endocervix. So the cervix is made up of ectocervix and endocervix. The junction between the cervix and the body is at internal os. And there's a small canal which is also called as endocervical canal. It connects the uterine cavity with the vaginal cavity, and its extent from the internal os to external os. Cervical canal has two orifices, one at internal os and another one at external os. The internal os, the internal orifice which connects it with the isthmus, and the external os to the vagina. When we see the cervix in a nulliparous woman, the external os is round, and in multiparous women, it's a transverse. Now, the portion between the corpus or the body of the uterus and the cervix is isthmus. It's a 1 centimeter long, narrow passage, and it connects to the corpus. Now, the corpus, it slides intraperitoneally, and internally it has got a triangular lumen which connects the isthmus and both the fallopian tubes. And the base of the uterus, which is on the front, on the uppermost, that is called fundus. And at term, the fundus may extend as high as up to the xiphoid process, that's a vertebral level 9. In the most of the women, the corpus is bent forward against the cervix at the isthmus, which is called anteflexion, and the long axis of the uterus is inclined towards the vagina, that is called the anteversion. So anteversion and anteflexion is important to know. Now, the shape and the size of the uterus depends upon the age, number of pregnancies, what is the hormonal status, is the presence of fibroids, they all change. The uterus is surrounded by a circumjacent connective tissue known as parametrium, and the peritoneum covers the uterus almost completely except at the ventral part of the cervix, and they form the two recesses, two small spaces where the peritoneum is not there. Ventrally, it is called as vesico-uterine pouch, and dorsally, it is called the recto-uterine pouch, that is pouch of Douglas. A uterus, the blood supply is the major supply is with uterine artery. It's a branch of internal iliac artery and partly from the uterine branches of the ovarian artery also. And that they come from the abdominal aorta. The major blood supply with the uterine arteries, they supply vagina, uterus, medial 2/3 of the uterine tube, ovary, ureters, and structure within the broad ligament being supply with the uterine artery. Uterine artery is basically a tortuous structure. And why it is tortuous? Because it gives the permission to expand when the pregnancy is there. Venous blood supply drains through the uterine venous plexuses, and it goes to the internal iliac vein, and that empties again into the IVC. That's a vena cava. Now, when the uterine artery enters into the myometrium, it becomes the coronary arteries, which anastomosis anterior and posterior as surface of the body of the uterus in the midline. So while entering, it becomes arcuate, and the radial arteries, they arise from the arcuate arteries, pierce the myometrium centripetally and anastomosis with each other, and form the stratum of vasculature in the middle layer of the myometrium. So uterine artery, arcuate artery, and radial artery. From the stratum of the vasculary, the basal and the spiral artery are given supply to the endometrium. Spiral arteries are the functional zone of the endometrium, which is cast off during the menstruation. So spiral arteries spiral in the shape, and they are like that. The basal arteries are the straight one. They go to the basal zone of the endometrium, which helps in the regeneration of the denuded endometrium. Once there is these are the nervous derived from the inferior hypogastric plexus, which supplies, and there is a sympathetic preganglionic efferent fibers. They derived from the neurons, last thoracic and first lumbar. So T10, T12 and T11, T12, L1 and L2, which synapses with the postganglionic neurons. This is the nerve supply of the uterus. The sympathetic preganglionic efferent fibers produce uterine contractions in non-pregnant uterus and a vasoconstriction. And uterine contraction in a pregnant uterus is under the oxytocin hormone. Now, the parasympathetic preganglionic fibers arises from the neuron second to fourth sacral spinal segments S2, S3 and S4. These three are the segments and they cause the uterine inhibition and a vasodilation, but these activities are complicated by hormonal control of the uterine function. So the nerve supply and the hormone, these are the correlated thing. Now the lymphatic drainage is fundus and upper part. There is a pre and para-aortic lymph nodes. Along with the ovarian vessels, few lymphatic form the lateral angles and the uterus travel around the long filament of the uterus and drain into the superficial inguinal lymph nodes. So all the lymphatics from the fundus and body, they go into this, and the middle part they drain into the external iliac nodes, and the lowermost part, that is the cervix, from the east side lymph vanish drains into three directions. The first direction is laterally to the external iliac and the obturator nodes. The second one is the posterolaterally to the internal iliac nodes, and the third one is posteriorly to the sacral nodes. Thank you. Blood supply of uterus. Very important topic for graduates, postgraduates and practicing OBGYN. The common iliac artery divides into internal iliac artery and external iliac artery. The anterior division of the internal iliac artery is a uterine artery. It goes towards medially. It runs medially and about 2 centimeter away, it crosses the ureter before touching the uterus. At the level of cervico-uterine junction, it goes into the uterus, the uterine artery, and at that level, it divides into two branches, the ascending one and the descending one. The ascending branch, it runs very laterally to the uterus and it is very convoluted, and it divides at the level of fallopian tube. It divides into three branches. The first branch is ovarian branch of the ovarian artery, and it runs towards the ovary, and the upper branch is the tubal branch of the uterine artery, which is into the mesosalpinx of the tube, and the third branch is the fundal branch, which goes into the uterus. The another supply of the uterus is ovarian artery. It comes directly from the aorta, and with the ovarian branch of the uterine artery, it anastomoses and supplies also, and at the level of hilum, it goes into the ovary, and this anastomosis is also the uterine, and same another branch is for the fallopian tube and anastomosis with the tubal branch of the uterine artery, and fundal branch is the third branch which supplies the fundus of the uterus. The descending branch of the uterine artery, it supplies the cervix and the upper portion of the vagina. The another supply is from the internal iliac artery for the uterus is vaginal artery. It also directly comes from the anterior division of the internal iliac. This vaginal artery, it anastomoses with the descending branch of the uterine artery and supplies all the vagina. The uterine artery, there are few branches which directly go inside the uterus, and these are, it's a similar pattern in the other side of the uterus also. Now there is just a one cut section of the uterus to tell about the detail about the internal supply of the uterus, that is the serosa, myometrium and endometrium. There are branches From the ascending branch, there is a one branch which goes very close to the serosa and attaches with the other side of the uterine artery. This is called the arcuate artery, which is very close to the serosa and into the myometrium. This is a arc shaped, that's why it is called as arcuate artery. And this arcuate artery, there are branches from the arcuate artery. They are right angle from that is called a radial artery. This radial artery goes into the myometrium, and they are arcuate arteries. In the cut section we can see they goes into the myometrium and goes through myometrium and go into the endometrium. These are the radial artery. Radial artery is very, very important. It has got two branches. One is the basal artery and another is the spiral artery. Basal artery is basically the straight one. It's a straight artery, short and does not respond to the hormones. And the another is the spiral artery. It's a long, very, very long. It's a convoluted going up to the into the endometrium, and it is respond to hormonal changes. So the spiral arteries are very, very important for any changes into the uterus, as well as it's important for the pregnancy. So this is the supply of uterus. Thank you so much.